My name is Dr. Michael Wassef, and I'd like to welcome you to this educational presentation regarding the non-crestal dental implant system for removable prosthetics. Before we get into the PowerPoint presentation, where we will review the system in detail, I'd like to just go over a few parameters with you now regarding the system. Firstly, we will discuss briefly how conventional dental implant systems currently work and some of their limitations. We will then discuss a brief overview of the Dentsure-Lok non-crestal system. So, beginning with conventional dental implants, when a dental implant system is utilized to retain a removable prosthetic, the vertically placed or near vertically placed dental implant is inherently serving two functions. One, it retains the prosthesis, and secondly, it also bears masticatory load and transfers that load into the peri-implant complex. This system works wonderfully, and when there is enough bone volume and there are no anatomical limitations, this system works very effectively. In comparison, the non-crestal system, which we will talk about today, later in some more detail, is that it is for retention only. That is one of the big distinctions of the system. It does not support or transmit occlusal or masticatory forces to the peri-implant complex. This is one of the major highlights of the system. So how does it work? What does it do? What is its purpose? Well, we begin by placing it via a non-conventional trajectory. We call it the omni-directional trajectory, which is placed through a non-crestal approach. And basically what that means is that the implant is not placed through the alveolar ridge at all. It doesn't contact the ridge, nor does it go through the ridge. So how do we place it? Well, we place it pretty much anywhere else into the jawbones that we are able to engage the bone. What is the purpose of this placement? The purpose of this placement is to engage otherwise unusable bone that one cannot reach or possibly reach through a vertical approach, which is a traditional conventional dental implant approach. The prosthetics of the non-crestal dental implant system for removable prosthetics is geared, designed, and engineered to not transmit occlusal load to the implant. The way it does this is by its unique prosthetic attachment. Fundamentally speaking, there is no direct hard tissue to hard tissue contact. So the denture goes in. There's a channel in the side of the denture, which we will talk about, and there's also a sliding bar mechanism. Once the denture is seated in the mouth, the patient can then activate the slide mechanism and engage underneath, if we're talking about a lower denture, underneath the abutment, also known as the retentive element. There's also a resilient liner, which we will talk about in further communication just a bit down the line in the presentation. So fundamentally, it's non-crestal. That's the approach. It doesn't go through the ridge. It doesn't support or transmit axial loads to the peri-implant complex. It's made for retentive only. It is not made for fixed prosthetics. It is not designed for single implants. That is basically the function and the purpose of this system. The hope is that this will expand our options as clinicians to what we offer our patients. One of the highlights of the system is that it can be used as a standalone system or as a hybrid system in combination with conventionally placed dental implants. I would like to thank you once again for joining me. Thank you for sharing with me one of your most prized commodities, which is your time. I hope you enjoy it. Thank you very much for joining me. Hello, and welcome to this educational session regarding the Dentsure-Lok Non-Crestal Implant Retentive System design for removable prosthetics. My name is Michael Wassef. I am a general dentist practicing in the Phoenix area. And this educational information is intended to present the biomechanical principles, theoretical engineering rationale, and potential applications of the Dentsure-Lok Non-Crestal Implant Retentive System for removable prosthetics as a non-load-bearing, retentive-only approach for tissue-supported removable prosthetics. We will talk about many things relative to this system. I apologize in advance for redundancies throughout this session. There are quite a few concepts that need to be thoroughly and intimately understood about this system. Firstly, we will start with conventional implant systems. We will discuss the mechanical separation of retention versus load-bearing. We will discuss the purpose and parameters of the non-crestal system. Conventional implant therapy, biomechanics, and challenges is what we will discuss first. In removable implant prosthodontics, conventional treatment plan typically rely on vertically placed load-bearing implants. When adequate vertical bone height and width are present, this approach is predictable and well supported in the literature. However, many edentulous patients present with varying anatomical limitations. These may include only one or a combination of the following: reduced vertical bone height, ridge resorption, proximity to the inferior alveolar nerve, or sinus pneumatization in the posterior maxilla. In these situations, conventional implant placement may require augmentation procedures, altered implant positioning, or may not be feasible at all. Ridge dimensions do not always present proportionally. In clinical practice, patients may exhibit adequate vertical height with insufficient ridge width, or conversely, sufficient width with inadequate vertical height. Regardless of which dimensional limitation is present, the patient may not qualify for conventional vertically oriented implant therapy without modification of the site or sites. In such situations, clinicians may consider procedures such as ridge splitting, ridge augmentation, block grafting, or sinus elevation to create sufficient bone volume for traditional implant placement. However, these interventions increase treatment complexity, extend overall treatment time, add financial cost, and expose the patient to additional surgical morbidity. Even in cases with acceptable bone volume, implant trajectory constraints and prosthetic space limitations can affect restorative design and retention performance. As a result, a subset of patients either undergo more invasive procedures, accept compromised prosthetic stability, or are not treated with implant retained solutions at all. The purpose of today's presentation is to examine an alternative retentive-only system design that separates retention from load-bearing mechanics and to explore its theoretical biomechanical rationale and potential clinical applications. This is what we just discussed and touched upon. In a tissue-supported prosthesis, one in which occlusal and masticatory forces are borne primarily by the denture base in contact with the soft tissue and underlying bone, in conventional vertically placed implant systems used with removable prostheses, Even though tissue contact remains present, occlusal load transfer to the implant is inseparably involved. This is a key point here. The implants function not only to retain the prosthesis, but also to share or assume vertical compressive load. They are intertwined and inseparable. Again, this is an important point. In contrast, within the non-crestal retentive only framework, the prosthesis remains tissue supported for occlusal function without vertical load transfer to the implant assembly. This is one of the highlights of the system, of the non-crestal system. In conventional implant retained overdenture therapy, implants are typically placed vertically or angled vertically through the alveolar crest and function as load-bearing fixtures. This constant mechanical framework of these systems inherently couples retention with load-bearing function, and that coupling defines the placement constraints and anatomical requirements. These implants serve two primary roles. The conventional implants. First, they provide mechanical retention for the removable prosthesis through an attachment mechanism. Second, they function as load-bearing structures, transmitting occlusal and functional forces into the peri-implant complex. In conventional implant therapy, these two functions are inseparably linked. This is important. The same implant that retains the prosthesis is the implant that transfers occlusal load. Retention and load-bearing are mechanically integrated within the conventionally placed implant and abutment. One does not occur independently of the other. Common attachment systems such as O-balls, locator attachments, or bar assemblies are used to secure the removable prosthetic. These systems require a defined path of insertion and, in most cases, relative parallelism between implants to allow predictable seating and disengagement. Clinically, achieving ideal parallelism is not always straightforward. When implants are divergent or convergent, insertion and removal forces may introduce increased axial and off-axial stress at the abutment interface and within the surrounding peri-implant complex. Over time, this mechanical strain may contribute to component wear, screw or abutment loosening, and crestal bone remodeling, in some cases, eventual implant failure. Because these implants are load-bearing, occlusal forces are transmitted through the implant-abutment interface into the peri-implant bone. As a result, implant positioning, angulation, and bone quality are critical to long-term stability. Restorative space further influences prosthetic execution. The implant platform, abutment height, attachment housing, and required material thickness must coexist within the available interarch and occlusal space. When vertical clearance is limited, clinicians may be required to modify tooth positioning to accommodate the attachment assembly. In certain situations, this may involve elevating the mandibular occlusal plane beyond what would ideally be selected for optimal aesthetics and function. In other cases, teeth may be positioned more anteriorly than preferred to provide sufficient clearance for prosthetic components. These adjustments are sometimes necessary, but they may compromise ideal aesthetic proportions, phonetics, and occlusal relationships. When anatomical conditions in prosthetic space align with these mechanical requirements, conventional implant retained overdentures perform predictably and are well supported in the literature. However, the defining characteristics of these systems remains the inseparable coupling of prosthetic retention and load-bearing function. This is what we just discussed. This is a common conventional scenario, as we've all seen. You can see by the photos, not much inner arch space, inner occlusal space. So to maintain a vertical, even though it looks a bit overclosed in this picture, one would have to accommodate all the required space to put the teeth in prosthetic function. This is a slide talking about the denture displacement forces in the clinical context. You can read it. Tongue-generated displacement capacity is a bit important, and we will talk about a clinical scenario later on in this webinar. We often hear patients discuss the repeated tongue-driven disengagement. Clinically, implant divergence or convergence to some degree is expected. Perfect parallelism is rarely seen. Displacement versus occlusal forces. Displacement forces are directional, muscular lifting efforts, distinct from occlusal compressive forces during mastication. This is an important distinction because this is one of the system parameters of the non-crestal system. It is designed to resist displacement of the prosthesis and not transmit occlusal or masticatory load to the peri-implant complex. Again, retentive-only response. The non-crestal architecture is engineered to resist displacement forces only. The bar lock, which is a prosthetic that is engaged and attached in the denture base, is what we will cover a little later. The clinical interpretation or application for this, again, is reiterating the potential displacement that the tongue can cause. Excuse me. The objective of the system is to resist prosthetic movement, or I should say, to resist prosthetic displacement, for movement always occurs. Retention is achieved without converting the implant to a support pillar. Here we're going to discuss the non-crestal system solution. It's designed for the clinician and for the patients, keeping in mind that we are hoping to enhance patient candidacy and expand surgical and prosthetic options for our patients. Having established that conventional implant therapy inseparably couples retention with load-bearing function, it is important to examine an alternative mechanical framework. The non-crestal design philosophy is based on structural separation between retention and load transfer. Rather than functioning as a load-bearing element, the implant is engineered to greatly minimize and functionally approach elimination of masticatory force transmission to the abutment and surrounding peri-implant complex. This is achieved in part through the prosthetic design, deliberately, which incorporates clearance architecture within the denture base. We will see diagrams a bit further down the line in this webinar. When the prosthesis is fully seated, a defined gap prevents hard surface contact between the denture structure and the abutment during functional loading. As a result, occlusal forces are absorbed primarily by the tissue-supported denture base and underlying structures, substantially reducing mechanical stress at the implant-abutment interface compared to conventionally vertically oriented load-bearing systems. In this system, the implant is neither designed nor intended as a load-bearing fixture. I'm sorry I keep repeating myself, but this is paramount to the system's success and design purpose. Its role is limited to providing anchorage for a tissue-supported removable prosthesis. Occlusal and masticatory forces are supported by the denture base, the mucosa, and the underlying bone. The implant does not serve as a primary support structure in this system. Instead, a different mechanical objective is pursued. The purpose of this system is fundamentally to resist displacement of the prosthetic device. The design is focused exclusively on stabilizing the prosthesis, not on supporting or transmitting occlusal load. Later in this webinar, diagrams will be presented to illustrate how the prosthetic attachment within the denture interfaces with the abutment to achieve this retentive function. This approach differs fundamentally from conventional systems. A few of the distinctions of the system. Because retention is mechanically separated from load-bearing function, implant trajectory is not governed by axial load considerations. Instead, placement is guided by identifying and engaging the most anatomically appropriate bone to optimize mechanical stability and support long-term prognosis. This flexibility permits utilization of bone regions that may be unsuitable or inaccessible for conventional vertically oriented load-bearing implant systems. This is fundamental to the system, to the non-crestal system, and it is one of the major distinctions of the system, is that we are no longer limited by a vertical crestal approach. We now can view the physiology and anatomy of the jawbones in a different perspective, and to include areas which we otherwise would not have included. Non-crestal placement refers to trajectories that do not originate from or follow the traditional vertical crestal pathway. This is key. Instead, the system is built upon an omni-directional placement capability, allowing the implant to be positioned along horizontal, oblique, or other anatomically guided trajectories based on available bone. This omnidirectional approach is a foundational component of the system. It provides the mechanical and anatomical versatility to engage bone regions that may be inaccessible to conventional vertically oriented implant therapy. By freeing implant trajectory from the constraints of a crestal or alveolar ridge origin, the system expands the clinician's ability to utilize available bone in ways that traditional implant placement simply cannot accommodate. We're going to go over a few definitions in the upcoming slides, as you can see. As stated, the non-crestal omnidirectional trajectory does not originate from or engage through the alveolar ridge. Again, this is a fundamental distinction of the system. It does not follow the vertical pathway. The trajectory is selected based on optimal available bone, not just simply what we can achieve going through in a vertical or near vertical direction. Displacement forces, as we discussed, is basically an attempt to dislodge the prosthesis from supporting structures. Engineered to resist prosthetic displacement. Again, a key element that we already touched upon is that occlusal forces are borne primarily by the denture base and underlying tissues. In conventional implant systems, retention and load transfer are inseparably conjoined. Here we're going to go over some diagrams, and we're going to discuss some of the non-crestal approach examples. These are just examples. There are many other, much to list, actually, too much to list. Almost endless possible trajectories. We can initiate the osteotomy from virtually anywhere it is clinically, prosthetically, and aesthetically advantageous to us. So the red circle in this picture shows a potential osteotomy site coming in from the buccal or facial. And those arrows, the blue arrows, indicate potential trajectories. And this is on a three-dimensional scale, XYZ axis. Here again, the potential placement zones. If we're looking at the jawbone, we as clinicians implementing this system will begin to look at the anatomy a bit differently. So here we have in the first diagram to the left, you'll see AP1, AP2, AP3. They basically represent anterior-posterior zones at different vertical heights of the jawbone. Second diagram, again, you're seeing those same red lines indicated from a cross-sectional view. And the third diagram, you're seeing the buccal, the crest region, and the lingual surfaces of the bone. The clinician will eventually begin to perceive the potential host bone from a different perspective from what they are used to on all three planes. The objective of this system, the objective of the trajectory, is to engage the best possible bone host sites in order to maximize implant engagement. Here's another diagram with that picture repeated, and now it's showing over here on the left side of the jawbone, which correlate to these areas here. A fundamental component of this system is its omnidirectional placement philosophy. Traditional implant placement can limit options in some patients. In contrast, this approach allows implants to be positioned along alternative placement vectors, accessing structurally favorable regions that may otherwise be unreachable. By permitting multi-directional trajectories, the system expands surgical flexibility and enables engagement of the most suitable available bone rather than being constrained by the vertical placement access alone. Here's another example of the non-crestal placement. Here would be the buccal, lingual, lower right mandibular cross-section. And here we can see it in a different view. This cylindrical abutment, which we refer to as the retentive element, because that's what it's used for. It's used to retain. It's not used as typically abutments historically have been known to do. Here's another example. If you're going in from the buccal, you can not only go toward the lingual, you can also go superiorly. Here, you can not only go toward the lingual, but you can go inferiorly. Keep in mind, you can also go inferiorly and posteriorly, inferiorly and anteriorly, if we can imagine this on a three-dimensional plane. Here is an example of two non-crestal implants placed with angled O-ball abutments or retentive elements. Here's where it gets a little fun. We can start to look at some of the individual parts of this non-crestal system. The implant assembly from left to right, you have the abutment screw, the retentive element, and the resilient liner, which is indicated here in a circular fashion that sits on top of the retentive element but doesn't need to be. It can be embedded in the denture channel, which we will look at later. And then you have the non-crestal implant fixture. The implant body and the orientation is designed specifically for the non-crestal placement. Here we have a system overview showing the maxillary model, the retentive element, the resilient liner. This is the bar-lock prosthetic attachment, and this is the maxillary overdenture. Cylindrical retentive element we already talked about. It serves as an anchor point for displacement resistance, not engineered as a vertical support column. The bar-lock prosthetic attachment is unique to the non-crestal system. It's embedded in the denture base as shown in the prior photograph. And the activation is a slide mechanism back and forth by the patient. So this is shown in the engaged position. If you can imagine the retentive element sitting here, there is no rigid contact between this framework and the cylindrical retentive element. And then as an extra insulation, we do place the liner, the resilient liner. As discussed, it's activated manually by the patient after full seating of the prosthesis. The resilient liner we talked about, it not only surrounds the retentive element, it prevents food impaction and provides cushioning during minor movement, dampening displacement forces. The bar-lock mechanism engages through defined slide channel, no rigid compressive interface under functional loading. That's the key of the system. That's one of the pillars of this system. Here is a side view, upper left lateral view, maxillary overdenture with the bar lock disengaged. So the pink in the middle is the abutment screw, the gray is the cylindrical retentive element, and the dark purple is the resilient liner. One of the key structural components is the deliberate clearance architecture within the denture base. So when the prosthesis is fully seated, a defined gap prevents direct hard surface contact between the denture base and the abutment or retentive element during functional loading. The resilient intermediary interface absorbs the minor retentive forces while preventing rigid force transfer. Here is the bar lock engaged. So we can see here that the patient would move the slide from posteriorly to the anterior area. And now the bar lock, which is rigid, is not in contact with the rigid retentive element. There's a resilient liner there. So even if there's movement, it's not hard to hard surface. There's a deliberate gap, which we talked about. No hard-to-hard interface during insertion or function. This produces several clinically relevant effects. One, it reduces mechanical demand at the implant abutment interface. It reduces stress concentration within the peri-implant complex. Also, elimination of divergence-related axial stress concerns due to a path of insertion in conventional attachment systems, and freedom from strict parallelism requirements. The bar lock, as seen in the previous photos, it's positioned farther away from the prosthetic teeth. The retentive element is located between the prosthetic and locking mechanism. I bring this up because this is in contrast to conventional implant systems that use housings or inserts that engage the implant abutment. So you would have the teeth on the mandibular denture, let's say overdenture. You would have the housing embedded and the insert into the actual denture base, And then lastly, the most inferior portion is the implant and abutment. So preserving this restorative space, because the retentive mechanism does not occupy the occlusal plane in the non-crestal system, we have the ability to maintain ideal prosthetic thickness without the need to over-contour the denture base to accommodate attachment housings or abutment assemblies. So we have greater freedom to position teeth according to ideal aesthetic, phonetic, and functional parameters, rather than adapting tooth position around hardware constraints. So we would get basically an improved occlusal plane control, avoiding the need to elevate the mandibular tooth position or shift teeth anteriorly to create clearance or room to accommodate the prosthetic hardware. We reviewed this. Here's a video of the system. Let's take a look. So we have all the parts here. Implant fixture, followed by the retentive element, followed by the abutment screw, the resilient liner, showing how the bar lock would engage the denture base. Slides closed. Slides back, disengages, and the patient can now remove the denture. So some of the biomechanical benefits of the non-crestal system we already touched upon. One of the defining features of the system is the deliberate clearance between rigid prosthetic components and the cylindrical abutment. During insertion of the denture, there is no rigid hard surface to hard surface contact between the denture base, the bar lock structure, and the retentive element. After engagement, that principle remains intact. Occlusal loading does not convert the interface into a rigid compressive contact point. A defined gap is maintained as part of the engineered architecture. This is an absolute must. So when we do seat the denture in the mouth and we can have the patient bite down as hard as they can, we have to make sure that there is no hard surface to hard surface contact. This is obviously intentional, and it prevents conversion of the implant into a support pillar. Some research here would show the reduced crestal bone concentration in the non-crestal system as compared to conventional. We obviously would have decreased risk of overload. Reduced micromovement at the bone implant interface. Improved control of bending movements in overdenture therapy. As we all know, in conventional therapy, and we've seen it, mechanical loading really directly influences the peri-implant bone response. If there's too much force due to divergence, convergence, or unnecessary forces, or the implant is angled in a way where the amount of force being applied to it over time, if the force being applied obviously is a bit too much, the implant can fail over time. Here we have the clinical integration and rationale. Here's some important comments here regarding the clinical integration. This is where it gets a little bit fun. The non-crestal system is designed for either or. It can be used as a standalone retentive solution or as a hybrid adjunct used alongside conventional vertically placed implants. The purpose of this section is to clarify how the system can be integrated logically into real-world treatment planning without requiring a clinician to abandon established implant methodologies. As a standalone application, this system may be considered in situations where conventional vertically oriented implants are limited or not feasible due to anatomical limitations. In this configuration, the system is used strictly as retentive anchorage for a tissue-supported removable prosthesis. The prosthesis remains tissue-supported for occlusal function while the implant's role remains limited to resisting displacement only. The key point is that standalone does not mean the prosthesis becomes implant-supported. It is not. It means retention is achieved through a retentive-only implant design while occlusal and masticatory forces remain managed by the tissue-supported denture base and underlying structures. In a hybrid configuration, the system can be used alongside conventional implants to assign different mechanical roles to different implant systems. Conventional vertically placed implants can be used where anatomy supports them and where the clinician intends them to continue functioning as a load-bearing fixture. In the same case, the non-crestal components can be used in additional regions specifically to resist displacement without functioning as load-bearing elements. So each system maintains its characteristics. Hybrid use makes sense and is logical. Clinical scenario 1, the edentulous mandible. This is probably common to almost all of us. A common clinical presentation in the edentulous mandible is that the anterior region, often described clinically as the interforaminal region roughly between the canine areas, may retain adequate vertical bone height even when the patient has been edentulous for many years. In contrast, as the clinician moves posteriorly, ridge resorption and anatomic changes often reduce available vertical height. The posterior mandible frequently presents with limited vertical bone due to the position of the IA and the typical pattern of posterior resorption. In this situation, the clinician may reasonably be able to place two conventional implants anteriorly. Those implants can continue to function exactly as conventional implants are intended to function. They can retain the denture and they can remain load-bearing. The challenge arises posteriorly. If the clinician attempted to place conventional implants in the posterior sites, based on this scenario, the available vertical height may not safely accommodate the implant length required. This is where hybrid integration becomes practical. In a hybrid approach, the clinician may use two vertically placed implants anteriorly, excuse me, and then use the non-crestal system posteriorly, potentially one implant per side to resist posterior displacement of the denture. Prosthesis remains tissue supported, and the non-crestal posterior components remain retentive only by design. They do not become load-bearing simply because conventional implants are present elsewhere in the arch. The distribution of roles is clinically intuitive. Anterior conventional implants remain conventional. The non-crestal remain with their characteristics. Excuse me. Occlusal and masticatory forces are borne by the denture base in contact with the mucosa and bone. The practical implication is that posterior denture lift or posterior instability, often a persistent complaint, even in otherwise successful anterior implant overdenture cases, can be addressed through targeted posterior retention without converting the implants into load-bearing fixtures. Clinical scenario 2, the edentulous maxilla. A parallel scenario exists in the maxilla. Clinicians frequently encounter adequate vertical bone height in the anterior maxillary regions, while posterior maxillary implant placement may be constrained by sinus pneumatization. In this scenario, a clinician may choose the same scenario we did for the mandible. 2 anterior vertically placed implants, and in the posterior region, the non-crestal implant. Hybrid integration offers another treatment planning option. We may begin to see things a little differently when treatment planning for our patients. We may begin to see that even a short vertical height may be possible for these implants to be placed. Why they matter. Anatomy is obviously regional within an arch. These two scenarios are intentionally straightforward because they reflect what clinicians see routinely. Anatomy is not uniformly favorable throughout an arch, and the constraints are often regional. Hybrid integration allows the clinician to treat the arch as a biomechanical system. Surgical considerations and placement philosophy, as you can see, it's guided by the anatomy, the omni-directional trajectory. The objective is to maximize prosthetic result via maximum retentive resistance of the prosthetic. We allow the anatomy to guide the trajectory. Indications and contraindications for the non-crestal system is basically fundamentally the same as in conventional systems. The system here is not limited to patients with compromised bone volume only or challenging anatomical conditions only. It may also be applied in patients with moderate to ideal bone architecture where prosthetic retention, trajectory flexibility, and occlusal space management are desired. Its versatility lies in its omnidirectional trajectory. I'm not going to read this all to you. You can see it on the slide here. You can go back to this video as needed. Case selection, obviously. So the contraindications are kind of important here to understand. If the intended use is as a primary load-bearing fixed support denture, then this system will not work, nor is it intended to work. It's only for retention. So we can't do fixed prosthetics using this system. And if we are unable to maintain the anatomical safety margins, as we routinely have in our conventional therapy. Obviously, other health conditions here listed for you. The essential point, or the essential principle, is that this system expands options. It does not replace conventional implant therapy. It provides clinicians with additional biomechanical and anatomical flexibility while operating within the same foundational medical and surgical principles that govern implant dentistry. We discussed this. Clearance must remain intact. Engineered as retentive-only architecture. Its function is to resist displacement. And I know I've said this many times, but it has to be really understood and acknowledged. I will say something about the bar lock. The bar lock mechanism itself is a rigid component, yet it does not create direct hard surface to hard surface compressive contact with the cylindrical retentive element during insertion, at rest, or under occlusal or masticatory loading. A 360-degree resilient liner interface remains interposed, maintaining separation between rigid structures. This separation must be preserved in this system. We talked about the prosthetic clearance. Not intended for load-bearing support, fixed implants. Here are some takeaways. Again, a key distinction in conventional implant therapy, those two functions are inseparably linked, which is retention and masticatory and occlusal loading. In the non-crestal system, that is not true. There is a disunion and a disengagement. Here's an important point. It's applicable not only to complete overdentures, but also partial removable prostheses. You know, if we think of a common scenario in clinical practice, we see a bilateral distal extension. Maybe there's not enough room in the posterior area to place conventional implants. Maybe one would want to place a non-crestal implant. In summary, the non-crestal concept represents a deliberate and structural, unique separation of retention from load-bearing. Again, I want to reiterate, it is not positioned as a replacement for conventional implant therapy necessarily, unless the clinician chooses to do a standalone case, but rather it expands our biomechanical and surgical options. Can be used as a standalone system, can be used as a hybrid system. It's versatile. Here is my contact page. Should you wish to contact me further, I'd be delighted to hear from you. I want to thank you for your time, and I want you to know that I thoroughly enjoyed presenting this to you, and I hope you enjoyed it as well. Thank you very much.